Referred to us because of an abnormal electrocardiogram and an echocardiogram. The question was whether he could be certified for a job. IV septum 15 millimeters, post left ventricular 14 millimeters, LV IDT was slightly increased 58 millimeters, LV IDS was 32 millimeters. Can we certify him for a job? That's the main question. Fully active young man, blood pressure was normal, no valvular heart disease, ECG of sinus bradycardia, borderline LVS, no arrhythmias. The LVH in the electrocardiogram was what brought this young man to the echo lab, and echo lab created more problems because of reading. Echo should concentrate LV hypertrophy. While LV IDS is normal, IDD is increased, diastolic dimension is increased. On questioning, he was a cross-country runner since childhood. How do you certify whether this person is normal? This is very classical of athlete's heart. You have concentric LV hypertrophy, but LV end systolic dimensions are normal. When you do a strain, 2D strain, you find that 2D strain pattern is completely normal. In fact, in some of the segments, the strain is definitely increased, which shows that the contractility is definitely normal, and hence this patient could be certified. Concentric LVH, often less than 40 millimeter, mild LV dilatation. It's a physiological adaptive process demanded by increased stroke volume, more so in cross-country runners, rowers, cycling, increased septal thickness in black athletes we described, and the high propensity of sudden cardiac death in athletes have been a vexing problem. How do you identify the athlete heart from those who are prone to develop sudden cardiac death? It is there that you look for septal thickness. Increased septal thickness is definitely an indication that these are the subjects who are variants of athlete's heart, who have very marked thickness of the IV septum. IV septal thickness is more than 30 millimeters. There is a 40% cumulative risk of sudden death. So from the athlete's heart, we have to separate up those patients, those subjects, I would say, those athletes who have specific septal thickness. And it is this septal thickness where you have myofiber disarray and who are prone to develop arrhythmias and sudden death. Way back in 1958, the first British reported hypertrophic cardiomyopathy, Sir Russell Brock, were all patients with systemic hypertension, long standing. He described septal thickness, outward duct obstruction, and named it hypertrophic subaortic stenosis. Same time in USA, idiopathic hypertrophic subaortic stenosis, IHSS, was described by Brownwald. Remember, in systemic hypertension, left ventricle do not have real concentric hypertrophy. There is a septal bulge which identifies the hypertrophy of systemic hypertension, which could identify many patients that this hypertrophy is due to systemic hypertension. There is a very specific entity, hypertensive hypertrophic cardiomyopathy. These patients also do have concentric hypertrophy with the diastolic dysfunction and reduced S waves, very classically. Many a time, these are patients in whom the hypertrophy is inappropriate. Patients with established systemic hypertension comes to with marked inappropriate LV hypertrophy. We may be able to differentiate the hypertensive heart disease from HCM by tissue synchronization imaging. This is one study we did some time back. Tissue synchronization imaging is what we look at. Timing from the onset of QRS to myocardial peak velocity. You find the peak velocity is depicted by the green color. If the peak velocity timing is delayed, it will become yellow and red. If there is dysynchrony in terms of reaching the peak velocity, that could be identified by green and yellow, which says that the peak velocities are arrived much later in the cardiac cycle. We found that in hypertensive hypertrophy versus hypertrophy secondary to hypertension, there is a difference in TSI variables. We found that the odd segment maximal delay and odd segment standard deviation was significantly different in patients who we suspected was inappropriate hypertrophy when compared to hypertension, which is in relation, the hypertrophy is in relation to the systemic hypertension. It's a significant.
Hello?
Coming to other variants, recently this patient came to me with severe hypertrophic cardiomyopathy. However, when you look at the free wall of the right ventricle, normal free wall is 3 to 5 millimeters. The free wall of the right ventricle was markedly hypertrophied, coming to 10 millimeters in this region. And this is patients who biventricular hypertrophic cardiomyopathy. Slides are not moving, please.
Video. This cut out memory lele. Photo camera.
Just a minute, let's get the slides back. Yeah. Computer is hanging, unfortunately. Okay. Back on screen. It's not this, yeah. This is another patient with marked thickening of the free wall of the right ventricle. You can measure the thickness of the free wall of the right ventricle at this point. Both these patients did not have any outflow gradient at the RV outflow tract. This is only simple hypertrophy of the RV inflow tract region with thickening of the free wall of the right ventricle. But RV definitely showed diastolic dysfunction with marked increase of deceleration time, 380 milliseconds, increasing diastolic dysfunction. This patient came to us with severe chest pain, with a significant marker elevation, and echo showed hypertrophic cardiomyopathy. But when we look carefully, you find that the hypertrophic septum is cut off at this point, and the rest of the septum is markedly thinned out, and this patient had a mid-LED lesion which was stented. Is a patient, it is well known that patients with hypertrophic obstructive cardiomyopathy with anterior infarction can have subherald gradients which gave the idea for alcoholic septal ablation. This is a 28-year-old lady who came to us with severe cardiac failure. Look at the MOD echo, massive hypertrophy outward of the IV septum. There's a severe, the marked gradient, 178 millimeter gradient across the outward tract of the left ventricle. And this resulted in hypertrophy of the right ventricle pulmonary hypertension, and PA pressure was 16 millimeters of mercury. Here is a right patient who has outflow obstruction, very high gradient, resulting pulmonary hypertension, and pulmonary hypertension producing right ventricular hypertrophy. The patient refused any intervention, and unfortunately, we couldn't do any intervention in this patient. What is the end result of hypertrophic cardiomyopathy? And the end result is a dilated left ventricle with reduced ejection fraction. Hypertensive heart disease versus hypertrophic cardiomyopathy in heart failure, you find it difficult to differentiate. Ladies and gentlemen, when you look in the literature, there have been 12 variants of hypertrophic cardiomyopathy which have been described, starting from near normal to the burned out, final end result with severe congestive heart failure, and try to show some of the variants which I could gather. Thank you.
Thank you, sir. We have the last speaker for the day.